very interesting case. He is a 30-year-old male with progressive deterioration in the mental function. As a teacher, he tries to forget. You can see here one aneurysm in the cavernous portion, another one in the neck. We did the balloon occlusion test. It failed. Then we did superficial temporal artery MCA bypass. And we used the STA because it's very big. Several months ago, he developed an aneurysm at the stump. Started to cut. He complained headache. Okay, let's observe. Give some aspirin. 2 years later, the stump of the bypass has grown into another giant aneurysm. So what to do? We did another balloon occlusion test. It was okay, and we occluded the stump of bypass depending on the collaterals from the ECA and PCA. After some years, the patient started to have headache. I was with some of this patient, and I remember we did together this case. We had a silk stent, and then in one Leo, and another silk stent because the answer was very bad. So to summarize what happened to this patient, cavernous aneurysm, and then bypass, and then the bypass has grown into another aneurysm, and then we did a balloon occlusion test, including the bypass, and then the patient has a PCA fusiform aneurysm de novo, and we cannot occlude the PCA because this is the essential. It gives a lot of PMC collaterals, and then we have to occlude it. So in one patient, we used several techniques. We used the balloon occlusion test, we did a bypass, and then we did another foot diversion. So I don't think we can ignore the fact that we need every method to treat every patient. There's no conclusion about which is better for the patient, to do current vessel occlusion or to do flow diversion. And there's no randomized control studies about this. So we need both methods, and the primary question will be, if you can flip it, it's okay. If you cannot, and this is the huge one, if you cannot flip a giant aneurysm, you ask yourself, can I do flow diversion for the aneurysm? If the answer is yes, you should proceed with flow diversion. If not, so you will need current vessel occlusion with or without that. So it's a case-by-case decision, and we should put in mind the aspect of finances and experience, because flow diverters actually are very expensive, which we thank you very much.
Thank you. It's a very interesting presentation with many difficult analysis.
Hello?
Can you hear me?
Hello, can you hear me?
Wait.
Please open your mic, Dr. Chi, in the left side.
Yeah. Can you hear me now?
Please open your mic. Please open your microphone in the left side. Down. Please open your mic, please. In the left side.
I'm dying now. Sao?
Dr. Chi?
Yes, I'm here.
Can you kindly unmute your mic?
Yes.
Unmute yourself. Because we don't hear your voice.
Yeah, I'm trying now. Sao gì sao?
There is a bar down in the screen. You can mute yourself. You will find a microphone icon, and you can click this icon to unmute yourself. Down the screen. Yes.
Okay. Thank you.
Yeah.
Very sorry for the inconvenience. Thank you for very interesting presentation with so many difficult cases. And I would like to ask one question, is okay? In the case you sacrifice the vessel, do you think about the detachable balloon or just only the coil for occlusion? trả lời đâu.
Chưa có hỏi nữa không?
Hello.
Click share screen button. Click share screen button.
Hello? Hello?
Yes.
Yes, we can hear you.
I would like to
Can
ask
you
a
repeat the
question.
question to the camera, please?
May I ask a question? Do you understand?
Yes, of course.
In the case you sacrifice the vessel, what do you think about the detachable balloon? Just only sacrificed by the coil, because the mass effect when you put so many coil in a very big or giant aneurysm.
Okay, that's a good question. If you have an ophthalmic giant aneurysm, you don't put many coils. You just put 5 or 4 coils to initiate thrombosis.
Yeah.
And then come back to the original vessel and occlude it. So I don't have any problems with a few coils producing any mass effect.
Yeah.
Contrary to this, that when the aneurysm shrink, all the coils deform it afterwards.
Yeah.
You don't have to put many coils occluding the aneurysm. No, you just have put few coils and aneurysm to initiate the coils and the aneurysm, open the neck, and do ligation.
Yeah. In Vietnam, we have detachable balloon, so we can use some detachable balloon to sacrifice the internal carotid artery. It's cheaper than the coil.
Yes, okay, but if you want to put, you cannot put the balloon inside the carotid artery. You may put some coils and then come back to the neck and put a few balloons.
Yeah.
It's okay.
Yeah.
I think his question
Do you have
why
any other questions?
you have to put the detachable balloon. I think this is.
As I showed to the patient, we did occlusion by coils, largely retrograde. And of course,
Yeah, so we have to finish the session. Pass the session.
okay, we will start the lecture of Dr. Franchi.
Yeah. May I start now? Okay.
Yes, please.
Hello everyone. I would like to share with you some of the experience to treat the ischemic stroke by intracranial stenting.
Dr. Chi, please share your screen.
Yeah.
Please share your screen. Please share your screen.
Yeah. Okay. Hello everyone. What we are doing now in the century of stroke, especially in many countries, almost we had the same thing. And let's go back to some of the basic study. And we find out that the intracranial arteriosclerosis disease is now approximately 10% of all of the ischemic stroke, but the rate is almost totally different, especially between the Western country and the Asian country. And in our country, it's also in our region, the intracranial stenosis, it can account for 50 to 60% of all of the stroke cases. And let's go back to review some of the basic study. All of you also know very well about the intracranial arterial stenosis. And Even we try to treat the patient with the high dose of Lavix and aspirin and anticoagulation, we have to take a risk of 20% of the patient who has severe intracranial stenosis. From 70 to 90% has a very high risk of stroke after 1 year. Even we treat with high dose of antiplatelet therapy. And is it the demand why we still need the intracranial stenting, or it means that we need to do something for the patient with very high level of stenosis from 70 to 99%. The patient will receive whether we think about the stenting or just receive the medication. And is it some of the guidelines, some of the acceptable indication when a patient who has the diameter of the vessel bigger than 2 mm in diameter and with the symptomatic lesion, and the patient had a reverse stroke and TIA and failed to treat with the medical management, we can think about the balloon angioplasty or even video stenting. And we have some risk study. It's very famous in the endovascular and medication. But actually in Asia, we don't trust the result of this study because, as you know, we have many procedures per year. And right now, 1 year we actually treat more than 100 cases of intracranial stenting. And especially nowadays, we need to do something when we treat acute ischemic stroke with failed thrombectomy. And sometimes we cause the dissection of the vessel. We can do the intracranial stenting in emergency state. So, which way will be the good way for the patient? Actually, we cannot guarantee with the medication will be good for the patient. Otherwise, we need to do stenting on the cases. Let's go through. That's why in Asia, we organize a lot of meeting for the intracranial stenting and discussion with the neurologist whether we choose which kind of the treatment. And just to remind you, even we have the best medication, we don't know whether it is the best. In the severe stenosis, nearly occlusion, what is the risk of the recurrent stroke and the main trunk of the blood vessel stenosis, like the internal cardiac artery, the vertebral, the basilar, the middle cerebral. And what about the cerebral blood flow? And what about the risk of stroke for this kind of patient? And when the medical therapy fails, how about the patient? Any risk of death and disability when the patient has a recurrent stroke? And another story is the side effect of the maximal medication, the high dose of long-term antiplatelet like the bleeding, very high risk of the patient. The other hand, when the neurologist asks the neurointerventional so many questions, do you consider what's about the stenting result with the more experienced neurointerventional? We also don't know the risk for the patient. And this is some of the risk of the intervention arm. The size of the stenosis is nearby bifurcation. Like bifurcation of N1 or basilar is very difficult to deploy the stent in that kind of the lesion. And what's about the severe of nearly occlusion and lung segment of unstable plaque and calcification? It's very difficult to make sure that the procedure will doing in smoothly. And what's about the procedure? Communication, we cannot guarantee 100% of the patient has a good outcome after we do the stenting. And we can sometimes call the dissection, the rupture, and spasm, and the risk of death and disability is also patent. And with the long-term result, what's about the restenosis, occlusion, and recurrent stroke after we do the stenting? And the last is about the cost of the procedure. It's much higher. And in our experience, we choose the patient like this. We think about the stenting when the patient had a large vessel bigger than 2 mm and the stenosis level more than 70% and symptomatic lesion. We never treat the unsymptomatic. We never treat with the stenting. And the characteristics of the lesion is not longer than 15 mm and not at the bifurcation and not at the acute angle, unstable plaque, and around the dangerous perforating. We have to do with carefully. And the anatomical of the patient is accessible. And especially the last territory is not in very high risk for the patient with a medical condition, a very high risk like severe heart failure, CBD, kidney problem. Actually, we don't choose that kind of patient to do the stenting. And this is summary of the procedure technique. Reconnection with the dual antiplatelets at least 3 days before procedure. We normally perform the procedure under the general anesthesia, the heparin and balloon relay with the 2 mm balloon and very slow inflation. And we can accept the residual stenosis less than 30%. We don't try to do dilation too much, especially after we deploy the stent. And after procedure, we keep the blood pressure below 140, and what treatment care, we keep the blood pressure normal, what procedure, heparin, nose, and long-term anticoagulation. I think everyone know about the way of the treatment. And the stenting procedure is quite common. And currently now we have performed more than 200 cases of intracranial stenting, and this is the review when we finished 150 cases. Almost 50% of the patient have the intracranial terminal ICA. It's about 50%, and at the M1 about 28%, and basilar 11% vertebral. And we have some cases the patient has severe stenosis at the A1. And clinical of 100 cases, most of the patient is male patient, dominant, smoking, and diabetic, hypertension, and high cholesterol is normally. And this is the first case in Vietnam have performed about in 2007, it's about 13 years ago. It's a female, 63 underwent 4 times of stroke, and during medical treatment, you see the infraction here, and during the angio, you can see it's severe stenosis at the M1, and it's after we deploy the stent, and it is stent inside the vessel. And this is another case. The patient has 79 repeated TAA and vertigo and medication failed, and the patient has no right vertebral, and also he has severe stenosis on the left side of the vertebral, and he's in the before and this after we did the stenting with the wristband immediately after procedure. And this is a stent, I think you can see. And 1 year, so surprised, you see that after 1 year of the treatment, well, even if no restenosis, but you can see its supply to the brain is even better before. When we do the stenting, you see that, and 1 year, very nice. And this is the case after the SAMRIS study, we select the patient more carefully. This is a female, 73, she went to the hospital with repeated TA and aphasia and weakness, no history of hypertension or diabetes. And this is MRI, it's okay. Some minor stroke here, and with the angio, she has severe stenosis at the left internal carotid artery at ophthalmic segment, And for this case, we did the scan to see, and you can see that on the left side, the blood flow to the brain, all the territory M1 or MA1 degree significantly. And just because the sample study, we put the patient with Plavix and Artosic and starting with very high dose, but after 1 month, she has another stroke, and that's why we decided to do stenting for the patient. And during the procedure, even we did the second angiogram, even we treat with a very high dose Plavix and Aspirin, the vessel still progressive severe stenosis, even more. And this is the procedure. We dilate with the 2 mm balloon, and after that we deploy the stent successfully. And after procedure, we took the spec again to clarify everything, and so surprised because all of the vessel come back to normal, supplying to all of the territory of the vessel. And right now the patient still working very well with almost totally recovery. And this is the answer after 1 year follow-up. The patient now doing very well. And another case, very good case to learn, male patient, officer with hypertension, diabetes, and smoking. The first MRI, we saw the patient has stroke, and we have the treatment with the Plavix and Aspirin is very high dose. And this is the MRI. After we treat the patient with Plavix and Aspirin, the patient has gastric bleeding, and the dose much reduced. After that, the patient has stroke at the third time. And this is angiogram. We can see on the right side severe stenosis at the M1, and also on the left side not so severe, it's about 50%. And that's why we just do the stenting on the right side, and we dilate here and we put the stent. We don't treat on the left side because the level of stenosis it's about 50% only. And after Plavix and Aspirin, the patient a few months ago went back to the hospital now at 1 year, and a few months ago, after 11 years, the patient went back to do the control. We so surprised because no stenosis, stenting is can be durable even if 11 years. And for this case, the patient still keep going with the treatment, Plavix every day, and control the hypertension and diabetes is very well resolved, and the patient work normally. And this is another case, the patient, very young male patient, 48, engineer, and came to the hospital a long time ago and with stroke. And you see a lot of the lesion. And the patient has a totally occlusion on the left side of the carotid and severe stenosis at the basilar, I will show you. And the patient has not supplied to the basilar from the right side of the vertebral. The patient only supplied to the basilar from the left side, but nearly occlusion like this. It's very difficult to make sure that we can go through and dilate the vessel. But after we treat with the dual antiplatelet, we try to do everything, stop smoking, but the patient has the symptom back after 3 weeks with ataxia and weakness, and left side, on the left side weakness. And this is a very difficult case. Now the neurologist send the patient to do the stenting, but we can do or not. We are trying to do, but we cannot guarantee what happened for the patient. And this is the case. We navigated the wire, we dilate the vessel, and finally, luckily, we can reserve the left vertebral artery supplied to the basilar, and you can see here, it's a very nice result. And the patient now currently still working very well. It's a few years ago, but no any symptom. No stroke anymore.
Dr. G, yes.
Yeah.
So sorry.
Yeah.
Yeah, we have to finish summarize. conclusion. Please come to conclusion.
Yeah. And
Thank you.
this is the last slide. The very young male patient, severe stenosis at the M1 on the left side. And you see we did the stenting during procedure and deploy the wristband. And I will show you the post stenting procedure with a very nice result. And just let's go to the last slide about the conclusion. We started to do the stenting from 2006 up to now. We have performed more than 200 cases with the technical success rate is 98%. The complication about 2.5%. And we actually should choose the patient. Some patients can be benefit with the intracranial stenting, but some other can be treated with the medication. It depends on how you choose and how it is symptom of the patient. And the last slide, I would like to invite you come to Vietnam for the workshop for next year. Thank you for your attention. Okay, any question?
Thank you, Dr. Kanchi. Yeah, I have a question about the. Did you have how many percent of your patient has hemorrhages after stenting?
Less than 1% in our series. I mean that up to now we have very few bleeding complication after we deploy the stent.
So how do you avoid the bleeding complication? You undersize the size of the stent, or what do you do?
We dilate the vessel with very small balloon on the cases with 2 mm balloon. We don't try to dilate too much. And I think the most important is we keep the wire, especially with the wristband. Technically, we need to use the 300 cm wire. We need to control very careful and navigate with the X-train technique with the small wire, navigate to the diptol up to the entry and after that exchange to the 300 wire. This is our routinely procedure. And we can avoid.
You use all. Okay. You use wingspan in all the patients?
Yes, almost all of the cases.
Wingspan only, all the cases?
Yes, almost 100% of the cases with the wingspan, but sometimes for the emergency, for the easy case, we can use the coronary stent also, especially for the scalpel, we can use sometimes with the coronary stent.
Yeah. Thank you.
At the ophthalmic.
Okay.
I just have one question. Is there a difference in the technique between anterior circulation and posterior circulation, like a mid-basilar tight stenosis? Because I think it's more risky, or it carries some sort of more incidence of complications. So do you use certain technique in the balloon dilatation? And also another question, do you use coronary stents, or you don't, which are balloon-mounted stents, or you don't use?
The first, in the case nearly occlusion, yes, we treat with the moderate, severe, and you see with the high, high risk of complication. I recommend not to wait for the patient up to nearly occlusion. We should treat at the level of about 90% of stenosis. We never treat at level at less than 70%, never. And to maximum reduce the risk, I actually don't recommend to use the balloon mount and the stent like coronary stent, because we will apply the very high pressure to overdilate. We can make the vessel even make it bigger than the normally with the self-expanding stent. I mean that intracranial need very soft stent, but has enough radial force to keep the vessel open. That's enough. We use only for the coronary stent or balloon mounted expandable from the ophthalmic to the scalpel at all. We don't use the coronary
Okay.
stent for the M1. Yeah.
Okay.
Yeah.
Thank you. Thank you very much.
Thank you.
The stage is yours, cameras.